Assalamu alaikum. Dear all, today we are going to examine chest in this young gentleman. Examination of chest. First we'll be doing examination of front of chest, and lately we'll be doing examination of back of chest. As far as any examination is concerned, the examination rules are 4 things right at the start of examination. After sanitizing your hand, which we have already done, we'll be approaching from the right side. We'll be introducing ourselves with the patient, telling my name and asking about his name. The next is I'll be doing the proper exposure after taking proper consent. Proper exposure of chest is you need to ask the patient to take his shirt off. Wherever you find the female patients, due to ethical consideration, you can ask the examiner there, and then examiner can let you know that limited exposure will be allowed in those settings. And for back examination as well, obviously, the exposure will be the same. So these 4 things you must always know at the start of examination and at the end of examination, saying thanks to the patient and recovering the exposed parts. That's of utmost importance. Now, what should be the appropriate position in exam? In exams, the position of chest, for chest examination, usually you will find the patient lying on the couch, flat or sometime at 30 to 45 degree. So that's very fine. At this position, you can also visualize the JVP when you are checking things in addition to the chest examination. It's always worth remembering and memorizing that you know the number of points you are going to examine while doing a certain step over regarding a certain system. So in chest examination, as we are starting with inspection, so what are the points on inspection? The first point is respiratory rate. Then we'll be seeing the respiration, type of respiration. We'll be examining for chest movements. We'll be looking for scars. We'll also be looking for engorged veins. So starting with this examination, if you will be having these things in your mind, you will be proceeding the right way. At what positions you are going to stand so that you would be able to see chest the normal way. The position which is of utmost importance is going towards the foot end and looking for the chest shape and symmetry. So as I have highlighted, the first thing is respiratory rate, and the second is then chest shape and symmetry. Third is then type of respiration, and then rest is scar marks and engorged veins or all those things. So I'm going towards the foot end, looking for symmetry here. Respiratory rate should never be counted that way, where you are focusing towards that chest and patient can get anxious that way. Always hold the apex, hold the pulse, and show as if you are counting the pulse rate. And meanwhile, you would be assessing for respiratory rate. So after respiratory rate, after seeing the shape of the chest, looking for its symmetry, and after assessing for chest movements, now I need to look for scar marks and engorged veins. Remember, the only situation where you can find it a bit difficult is a situation where a person would be having hairy chest. So in all those situations, you need to have a torch with you, and you need to remove hairs throwing torch so that you can visualize every scar the right way. Always remember to see towards the sides as well. So I'm seeing the both sides. The scar marks of chest intubation, sometime pleural tap, will more be in those sides. So that is all about inspection. Moving ahead, the next thing is then palpation. In palpation, the first thing is, as you are going to touch the patient, he might have tenderness somewhere, or he might have crepitus. So that's the first thing. And then the next point is going to be, first thing is tenderness, crepitus. Second is palpation of trachea. Then the third thing is palpation of apex beat. Fourth thing is assessing chest movement with expansion. So one, you would be examining with your hands, and then with the measuring tape, we'll be assessing for, we'll be doing the chest expansion. And remember, chest expansion should never be done when patient is lying flat. When patient will be sitting, only in that position we are supposed to look for expansion. And the last but not least, that will be vocal fremitus. Just remember, if in an examination you are checking for vocal resonance, on occasions you can skip vocal fremitus so as to save time. However, there are few situations in which a patient's vocal resonance and fremitus may be suggestive of different things. So starting with the palpation, first I'll be asking the patient whether he is having pain somewhere, so that I'll not be causing any discomfort to the patient. आपको दर्द तो नहीं है कहीं भी? Remember always, supraclavicular region is also part of the chest examination because apex of the lung is there. So I'll be just palpating the chest that way. And remember, when you are palpating the chest, tenderness is the facial expression of pain as you are palpating a chest. So I'm palpating all the areas and looking for the tenderness. So there is no impression of that tenderness. The step next is, after examining for that tenderness and crepitus, complete examination. So please remember, in the palpation part, after tenderness and crepitus, we have to check for trachea. So how to check the trachea? So you can bring it close now. So how to check for trachea? You are seeing this thing here. This is Adam's apple. So you place two of your fingers, one the index and then the fourth one at sternoclavicular joints, and with that middle finger you keep palpating tracheal rings that way. And remember, most important is that in this suprasternal notch, you need to place your finger on that side, then on that side. If say there is tracheal deviation towards one side, you would be able to dip your finger down on the other side. If there is tracheal deviation to the other side, you will be able to dip your finger down in the suprasternal notch on that side. So that's how you examine the trachea. Next thing is then apex beat. The apex beat, how to identify it, how to place your hand, that has completely been described in another video of precardium examination. It is important because in those situations where a chest will be deformed, say a person is having kyphoscoliosis, there will be deviation of the apex beat, so it's very important. The step next is then looking for chest movements. So how to look for chest movements? And before proceeding for chest movements, as I told you earlier, that on inspection, we were looking for these chest movements. One thing you are always supposed to remember, that as I was examining chest for these chest movements, one is you see with normal breathing. The second is you always let the patient know, लंबे लंबे सांस लें जी, लंबा सांस. So it's always very important to assess for that chest movement on deep breathing. So same way I'll be doing here. So this is the first area where I am supposed to place my hands. So I am placing my hands here beneath the clavicular area. That way I'll be placing my hands, and now I'll be looking for this movement of mine. आप थोड़ा सा मुंह इधर को कर लेंगे, ऐसे लंबा सांस लें. ठीक हो गया, एक दफा फिर. So at least twice. Now my step next is, this is how you place your hands. Place firmly your fingers in this intercostal area, and your thumb should approximate. If they can't come closely, that's very fine, but that's the position. And just above the nipple, I am examining for that chest movement. लंबा सांस लें. So I am asking the patient to breathe in deeply. एक दफा फिर जी. ठीक है, बहुत शुक्रिया. एक दफा फिर. ठीक है. और एक दफा फिर. बहुत शुक्रिया जी. So this is chest movement. Remember, chest movement is never increased. It's always reduced or normal. So always comment like that. And wherever place it is reduced, that is considered the diseased side. Then moving ahead, Expansion, as I have highlighted you, it is always checked in sitting position. So as I'll be examining the back of the chest, I'll be telling you about expansion. Finalizing with the chest vocal fremitus. In vocal fremitus, as you know that you need to examine things at how many areas when you are examining the front of chest? Supraclavicular, infraclavicular, inframammary and lateral mammary. So whenever you are going to describe your findings, remember the golden rule that while examination of the chest, you are supposed to tell about your findings based on these anatomical areas. When you look at the X-ray, you give the findings based on zones. But when you examine the chest, you give your findings based on these anatomical landmarks. So infraclavicular, supraclavicular, inframammary, lateral mammary, that is where you are supposed to give your certain findings, whatever you are finding in these areas. What about the vocal fremitus? This is the part of the your hand you will be placing here. It's supraclavicular area. बोलिएगा जरा 1 2 3
1 2 3
फिर
1 2 3
फिर
1 2 3
फिर
1 2 3
जी
1 2 3
सही
1 2 3
बिल्कुल सही एंड देन एक्सिलास फिर बोले
1 2 3
फिर
1 2 3
फिर
1 2 3
फिर
1 2 3
ठीक है जी बहुत शुक्रिया सो इट्स a sound which produce like 99 or wherever you ask them to speak the word tin tin. I mean there should be some sound which you can appreciate by checking for that vocal fremitus. So याद रखिएगा कि इसमें 1 2 की अहमियत नहीं, अगर हम उर्दू की बात करते हैं इसमें 3 की अहमियत है. So जो वर्ड 3 है वो जब पेशेंट बोलता है तो वो आपको अप्रिशिएट होता है, उसकी एक वाइब्रेशन सी आपको फील होती है इस पे. What next then? We are going to start with the percussion. Percussion, first we'll be percussing for the upper border of lever and then we'll be doing the rest of the percussion. So as far as the percussion of the upper border of lever is concerned, you need to first identify this ridge. Then after moving from that ridge, you move to the second space. And remember, a percussion rule is you percuss usually on the middle finger over the with the aid of the middle finger of the other hand, and you percuss from the resonant towards the dull area. Preferably you should percuss twice and then you keep moving. Remember, the percussion over the chest should always be done with some strength. If you are doing percussion over the abdomen, it should be light. So these are the golden principles. Over chest with some strength, over abdomen that should be light. So that's how I'll be percussing. And here there is impaired note. So the impaired note suggests that this is the upper border of lever. So after assessing for that upper border of lever, now I'll be doing percussion by comparing both sides. First, I'll be striking here, then over the clavicular bone, then underneath. Here, this bone, underneath. So I'll keep comparing as I have done percussion up to that area. So this area is all fine. Here, after the second space, there is area of cardiac dullness. So I'll move laterally now. At least percuss thrice in these areas. 3 times percussing is enough. So that's how you percuss. Obviously, the percussion note is normal note is resonant. It can be hyperresonant in the setting of pneumothorax. It can be stony dull in the setting of fluid. It can be dull in the setting of consolidation. This you can read from the books as well. So after doing percussion of the front of the chest, and there is another type of percussion which you call tidal percussion. You can read it in the text. That is usually not done in exams. If somebody ever asks you specifically in the pulmonology exam, you should be aware of these terms. After this percussion, the next step is then auscultation. Now, as far as auscultation is concerned, in auscultation we'll be checking for 3 things. Number 1, auscultation of breath sound, its intensity and character. And again, I'm highlighting the same thing. Intensity is either reduced or normal. Never say intensity is increased. So intensity and character. Character is, sometimes sound is normal, character is vesicular. Sometime you may find bronchial breathing, and sometime you may find kind of broncho-vesicular character. This is not a very common finding, but you may find in certain situations. Then next is added sounds. Added sounds are crackles and wheezes are the main added sounds. Occasionally, you would be hearing the pleural rub as well. Rest of the sounds, there are few. You can find them in literature, but for exams purpose, they are not that important. So, breath sound, intensity and character. Then the next thing is added sounds, and finally, we'll be checking for vocal resonance. So these are the total things as far as auscultation is concerned. How to auscultate, in which areas you are supposed to auscultate. Remember, as you have got a small space in the supraclavicular region, so you should better either auscultate with bell, or if you have got some stat where on one side there is pediatric stat, on the other side there is the adult diaphragm, you can place the pediatric diaphragm here. So these are the, so that's how I'll be auscultating that area. And whenever I'm auscultating, I'll be asking the patient to breathe in deeply. ऐसे लंबा सांस लीजिए, ठीक हो गया. फिर लंबा सांस लें, ठीक है जी, बिल्कुल सही जी, लंबा सांस. So it's preferable that in exam you at least auscultate twice. फिर एक दफा, I mean you should at least let the patient breathe twice and then move to the next place. One breath, next breath, and then move to the next part. फिर एक दफा लंबा सांस. Fine, right? ठीक, फिर so that way I'll keep moving that way. Now I am moving to the axillas. Most of the candidates forget to see the axillas. Remember this thing, this is so important. Axillas should never be forgotten. Remember, all three lobes of lung are present in the axilla. Do not forget to examine axilla. थोड़ा सा ऐसे बाजू बाहर को निकालें, लंबा सांस, फिर so same way, let the patient breathe at least twice deeply, inside, outside, and that way you will be completing your auscultation, and finally you would be checking for vocal resonance. आपने 1 2 3 बोलना है जी,
1 2 3,
फिर
1 2 3,
ठीक. So in vocal resonance as well, at least ask the patient twice to speak 1 2 3 or 99, and keep moving in these areas. Now whatever finding is, I'll be describing this finding as, say a patient is having a dull note here, a bronchial breathing here. So I'll be telling the examiner, sir, on auscultation of the chest, on examination I have found a patient having a dull note in the infraclavicular area on right side, right infraclavicular area, or you can call it right upper chest. Sometime you can call right upper chest and right lower chest as well. So that's how I'll be describing my findings at the end of examination. You always describe your findings as, you always start your sentence as, I have examined the front of the chest of this young gentleman and on examination, and that's how you proceed with the things. So after completing that whole examination of front of chest, we are now moving towards back. The back examination, I'll be limitizing few things. Obviously, we have done few things already on front of the chest examination. We're moving toward back, and probably within next 5 to 6 minutes, we'll be over with the examination of the back of the chest. आप उसकी पोजीशन उधर कर लेंगे जी, उस तरफ को उठ के बैठें. चलें, ऐसे अपना हाथ आपने ज़रा ऐसे कर लेना है, यहाँ पे रखना है आपने, ये वाला बाजू, यहाँ पे ये वाला बाजू. आप बेशक नीचे कर लें इसको, आराम से ऐसे कर लें, ठीक है. Now the examination of the back of the chest, again it is inspection, palpation, percussion and auscultation. In inspection, obviously now we cannot visualize thing few things which we were able to do while inspecting the front of the chest. But here we can calculate the respiratory rate, that's must. So after calculating the respiratory rate, we'll be looking for some shape of the chest. Like if it is barrel, we can see from the back as well. We cannot probably see few things like pectus excavatum because they are on the front, but we can see few things like kyphoscoliosis on the back in a better way. Moving ahead, those points which I mentioned earlier will remain the same. After assessing for respiratory rate, after checking for the shape of the chest, what next? I'll be looking for scar marks. Scar marks, I'll be throwing light here, but it's difficult to see the axillas. So now remember, you have to do a certain maneuver. Whenever you are going to examine axilla, you just need to ask the patient to move his arms like that. ऐसे ऊपर को move करें. So that way, now I can visualize the axilla in a better way. ठीक है, दोबारा नीचे कर लें. So after completing with that inspection, I'll be moving towards the palpation part. Here I am not palpating the trachea, not palpating the apex beat. Rather, I'll be starting with the tenderness and crepitus. And as you have to see the tenderness, you need to see the face of the patient. So ask the patient to tilt his face towards you. आपको दर्द वगैरह तो नहीं है कहीं? थोड़ा सा अपना चेहरा ऐसे करेंगे, ठीक है. So again, I'll be watching carefully towards the face of the patient because tenderness is the facial expression of pain as elicited when you examine. Next is movement of the chest. As far as the movement of the chest are concerned, as I highlighted you earlier, you need to be at a distance. So I'll be here at a distance. I'll be asking the patient to breathe in deeply. लंबा सांस लें. So that way I am looking for the symmetry of the back of the chest and movement, whether they are equal on both sides or not. After looking for that movement, there is another very important movement as well. लंबा सांस लें. लंबा सांस. So what I am doing here, बहुत शुक्रिया, ये हाथ आपने थोड़ा सा इधर रखना है. What I am doing here, I am looking for supraclavicular fossa. Remember, in the examination of back, we'll be looking for things at 5 different areas. Supraclavicular, suprascapular, then interscapular, then infrascapular, and then lateral mammary. So back examination is of 5 different areas. So that way we'll be examining the back. And now I'm starting my things. So that way you are inserting your fingers like that, lamba saans lein, and you are looking for this movement actually upward. How your fingers are being lifted upward. Next is then lamba saans lein. ठीक है, लंबा सांस जी, लंबा सांस. So at least twice I'll keep on checking for chest movements that way. Here I'll be doing the chest expansion as well. For chest expansion, I'll be taking a measuring tape. With that measuring tape, which I'll be placing here, I'll ask the patient to breathe in deeply. Do not fix it very tightly. Let the measuring tape loosen as patient expands his chest. So do not make your own effort. You just need to place it here as he will expand his chest. By taking a long breath, that will move, and you need to measure the centimeters mentioned on it, that how many centimeter expansion is there in a chest. Moving ahead, after completing with this part, we move ahead to the vocal fremitus part. Same way vocal fremitus is done that way. 1 2 3 बोले.
1 2 3.
फिर
1 2 3.
Now I'll be placing my hand like that. जी फिर
1 2 3.
ठीक.
1 2 3.
फिर
1 2 3.
फिर
1 2 3.
फिर
1 2 3.
सही. अब जब मैंने when I am supposed to go to axilla, what I'll be doing, asking the patient to move that way. ये ऊपर को कीजिएगा जी. बोलें.
1 2 3.
जी.
1 2 3.
जी.
1 2 3.
जी.
1 2 3.
बहुत शुक्रिया. Thank you. So that is all as far as palpation is concerned. Moving ahead to the percussion part. Again, the first thing is obviously this area, supraclavicular, then this is suprascapular, interscapular at least twice at 2 different places. Now infrascapular, here, 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 and then axillas. Again, asking the patient to move that way. ऐसे कीजिएगा जी. बहुत शुक्रिया, thank you. So I'll be completing the percussion part. And finally, the last thing is I'll be doing the auscultation. In auscultation, breath sounds, intensity, and character. So as far as the character is concerned, either this is vesicular, vesicular with prolonged expiration, sometime bronchial, and very rarely bronchovesicular. Normally, you need to familiarize yourself with vesicular. Normal character is vesicular, and vesicular is with prolonged expiration is obviously seen in obstructive airway diseases, and bronchial is seen wherever there is consolidation, cavitation, collapse with patent bronchus. Then you will be seeing for you will be hearing bronchial breathing. So I'll be placing again, because this is a narrow place, so I am placing my bell here, lamba सांस. ठीक. So that I have already told you that it's preferred that at least let the patient breathe in, breathe out, breathe in, breathe out, then move to the next part. ठीक हो गया, सही. So that way I'll keep moving. Then I'll be placing my diaphragm in interscapular area on both sides. Then what I'll be doing next, placing it infrascapular regions at least twice. And then what I'll be doing, ask the patient to move his, ऐसे थोड़ा सा बाजू ऊपर कीजिएगा, लंबे सांस, फिर. So just for the sake of time, I'm doing it. Otherwise, let the patient breathe in deeply, let him exhale, let him inhale, deeply inhale, and let him exhale. ठीक है, बहुत शुक्रिया. And आखिरी, the last thing is then now vocal resonance. Again, I'll be checking the same areas. बोलिएगा 1 2 3,
1 2 3,
फिर
1 2 3,
फिर
1 2 3,
जी,
1 2 3,
ठीक हो गया,
1 2 3,
ठीक,
1 2 3,
फिर
1 2 3,
ठीक,
1 2 3,
and then at least
1 2 3,
once here as well.
1 2 3.
बहुत शुक्रिया. अब थोड़ा सा बाजू ऊपर कर लें, इधर 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 1 2 3 बोलेंगे और इधर भी 1 2 3 बोलेंगे. बहुत शुक्रिया. So this is all about the examination of chest. I'll be saying thanks to the patient, बहुत शुक्रिया, and I'll be recovering the exports parts. Thank you very much. Expansion should never be assessed while your patient is lying down. It should always be in the sitting position. So that way, I have hold this measuring tape. My centimeter side should be towards you. So centimeters are towards that side. And then you would be asking the patient to breathe in deeply. लंबा सांस लें, लंबा सांस, ठीक है. एक दफा फिर लंबा सांस लें, ठीक हो गया, बहुत शुक्रिया. So that way you measure it. The usual chest expansion is 5 centimeter in a normal person, and if expansion is less than 2 centimeter, then usually it signifies that a person might be having some problem which is not letting chest expand fully. Thank you very much.